All right. Hi, everybody. I'm Lauren Murphy. I'm one of the physicians at Boston IVF in the Brookline office. Coming to you on a Thursday afternoon. It's beautiful out there. And I'm looking forward to talking to you today just about really anything about fertility in general and, chatting about some questions. I think a couple of people wrote in earlier with a few questions that they wanted answered, so I'll start with those. But the other thing I just wanted to just make a quick mention of, for those of you who aren't aware, and I'm sure many of you are, this is Pregnancy Loss and Infant Loss Awareness Month. This is a big deal for all of us, but certainly in the field of fertility, and I just wanted to let those of you out there who have suffered a loss or are experiencing current loss to let you know that we are all here with you. We're here for you, and we're hoping to bring a little bit more light to this significant challenge that a lot of women face. So we'll be talking about that probably a little bit more later this week and this month in general. But, just know that we're thinking of you and we're here to support you in any way that we can. So it looks like we have some people that are joining. I'm just going to give a couple more, just maybe like 30 more seconds to get people in for the general discussion, and then we'll get started. But just a little bit about me while we're waiting to start on some of the questions. I am located primarily in the Brookline office, but I see patients from all over. I, will do Zooms. Actually, it's become primarily Zooms that patients like to pop into, and I totally understand that. It's very easy and convenient, but I also love to see real faces in person, so I'd love to see you in my office if that worked for you. I do see a fair number of patients on the South Shore, Quincy area as well, but again, really all over because now we have the luxury in a way of doing Zooms. So we have an amazing office here, a really wonderful nursing team is specifically that I work with, a wonderful team of women in particular. Quick shout out to my nurses, Amanda, Kendra, Heidi, and really all the people that kind of pop in and out of my team to help make it what it is. It's really couldn't do it without our wonderful nurses, great admin and financial coordinators too. So we're all here for you. So let's get started. I think one of the questions that I received was talking about just general success rates and asking questions about unexplained infertility. And I would say that this is, a very frequent topic that comes up in my consultations. Unexplained infertility can be both reassuring and frustrating when you get that diagnosis. I think for some couples, when you find out unexplained, you may sit there saying, well, if everything looks normal, all of our testing looks normal, why isn't this happening, right? And, the answer is, we don't know. It's unexplained. But the good news about unexplained infertility is that it typically means that there is, lots of good things that we can work with to make it happen for you, to help support the process and help you conceive a pregnancy. So, for example, unexplained infertility typically means that a female partner has good ovarian reserve testing or normal ovarian reserve testing, and it means that the male partner or the sperm source is also normal, and so we don't have a reason for why this isn't working. The good news, again, in those cases is that we have a lot of tools in our tool belt to assist, both with inseminations in that case, potentially, and with IVF. And the general sort of statistics of success rates here with unexplained infertility is that greater than 95% of couples with unexplained infertility will be successful in their process of achieving pregnancy eventually. okay? Now, how quickly that occurs and what you have to do to get there, that varies from person to person or couple to couple. But, again, I think it's has very positive outcomes that we would expect from there. One question that I often get, this wasn't in the one that was sent, but just I think it's important to mention. One question I often get from patients is, well, if nothing is wrong, if we don't find anything that's wrong, can we continue to try on our own and just use, like an oral medication like a Clomid or a letrozole to try a little bit longer on our own at home? And a lot of my patients and sometimes even some general OBGYN providers out there are surprised to learn that with unexplained infertility, there is no evidence to show that just the use of letrozole or Clomid alone with timed intercourse at home is going to change the likelihood of pregnancy any more than what you're already doing at home on your own. So really, when it comes to unexplained infertility, we need to at least be doing both a medication like Clomid or letrozole and additionally adding in an intrauterine insemination to give an improvement in the odds of conceiving pregnancy in that way, or consider going to IVF. So that's sort of just one thing to mention there. A couple of other questions that we received. There were some patients asking about prenatal vitamins and what to do while waiting to start the IVF process. And I think we just got a note that came in here about supplements and lifestyle changes. So this might address it all. Certainly, I think starting a prenatal vitamin is important for any woman who's starting to think about conceiving. It's ideal to do it a little bit before starting to try, but truly, doing this even when you first start the process of fertility treatment, it's not like you're behind the 8 ball. It's okay. You can start as soon as possible. And essentially, really any prenatal vitamin is fine. I think there's a lot of marketing as to, what's ideal and fancy packaging and all these things. But truly, the only thing you need from a prenatal vitamin is folate or folic acid, okay? So any prenatal vitamin is going to have that in it. And truly any women's multivitamin, even that's not labeled prenatal, is going to have that in it. So I tell my patients, any one that you can tolerate that doesn't make you nauseated is great to use. One that we can prescribe you is a tiny little gel tab called VitaPearl. A lot of my patients really like that, and sometimes it's easier to get it through prescription. It's kind of less expensive. So that's the deal with prenatal vitamin. As much as you can take it, I'd want you to be taking it. But again, if you forget a day or two a week, it's not a big deal, so don't panic. Other things that you might consider in terms of, adding to your regimen, vitamin D, I'm talking to you from Boston. We are in the midst of getting ready for fall. All of us up here are probably a little bit vitamin D deficient. So I think that, you would ideally consider starting a vitamin D supplement in your regimen just to support that through the winter. Other things that we often talk about in the fertility world that doesn't have tons of evidence but are things to consider. CoQ10, you might hear about this supplement a lot. That's something you can pick up at the regular pharmacy. There are some small studies that suggest that it might improve something with egg quality. There's not great data, but I usually tell my patients it's not going to hurt. It could help. So you might consider starting this too. 400 milligrams a day up to 600 milligrams a day. And that window is probably what I would try with that. Some other specific things we can talk about related to different conditions, but these are sort of the general things that I would recommend. Someone is just popping in a note about DHEA. There's some benefit to some. There is some negative outcomes to too much. So I would just be cautious. Like a prenatal vitamin with DHEA, that's sort of packaged together, great, but I wouldn't recommend going on high dose DHEA for an extended period of time. It actually can change how some of our labs read out. So, you just want to be kind of cautious with that. But moving on just a little bit to another very common question I get with fertility treatment and patients is this question about progesterone. And, how do I know, or, what if I have low progesterone levels? So this is an interesting concept and discussion because, of course, as many of you who might be in fertility treatment know, we do use progesterone a lot to support the uterine lining, to prepare a lining for pregnancy, to support an early pregnancy. But we often don't do a whole lot of testing on progesterone levels. And that's really because there is not a identified, threshold at which typically we're going to say this progesterone is way too low or this progesterone is too high. Typically, historically, there was discussion about this idea of having low progesterone and kind of getting your period too early after ovulation. People talk about this as a luteal phase defect. This is actually something that's been studied pretty significantly, and we really don't have data to support it. So at this point, typically, when we're doing any kind of fertility treatment, with IVF, we're always supporting with extra progesterone in different forms, vaginal versus intramuscular. If we're doing, a transfer cycle, we're almost always supporting with a progesterone after transfer. But usually if we're doing an IUI cycle, intrauterine insemination, we are not giving progesterone because the idea there is that you're ovulating an egg from a follicle, and that follicle is turning into a corpus luteum cyst, which is going to support support any implanting pregnancy, and that should be enough progesterone because it's really just the natural process there. So just a little bit about that. So in general, I'm not really in favor of just like empirically giving extra progesterone, say after you notice a positive OPK at home and starting progesterone a few days later. I mean, there's not harm to that, but there's really no data to support that. So hopefully that gives some clarity there for you. A couple questions about transfers and mock transfers. So I would say in general, someone had asked, is a mock transfer helpful? I think mock transfers can be very helpful in settings where, perhaps there was previous surgery on the uterus or a difficult time in previous insemination cycles in terms of getting a catheter into the uterus. And so I would just say that in those settings, if you have had a history of a difficult IUI experience, that a mock transfer can really be helpful. Or if you had a difficult transfer experience in the past, doing a mock transfer can just help map out that course. So I think that they can be useful. Do I do them all the time? No. Because most often, whether it be me who's doing a transfer or one of my colleagues at Boston IVF, we typically have the skills to be able to achieve a successful transfer for just about anybody who walks in that transfer room on day of transfer, even without a mock cycle. So, I would just say that. But in terms of, I know we're kind of bouncing all over the place, but just a lot of ideas here coming through. So in terms of pre-implantation genetic testing, there was a question about that process and how long it takes. And the actual process itself here from start to finish, this was kind of the question, is like, if you're starting an IVF cycle, how long after that might you be doing a transfer? So I'm going to just kind of walk you through what that process would look like. If you're starting IVF, Typically, you're going to be starting injections with a period or maybe after a birth control pill or something like that. And, you're going to be stimulating on average for 9 to 12 days. And during that time, you're going to be coming in for ultrasound, blood work monitoring. We're going to be making sure you're ready to go by the time we get to the retrieval, which is, again, usually at about the 2-week mark. Okay, so start of stimulation to retrieval is about 2 weeks. After that, the embryos then have to have time to grow and develop before we can biopsy them. And that usually is happening, 5 days to 6 days, sometimes even 7 days after the fertilization occurs. Once that biopsy is completed, the embryos are frozen, and so they remain untouched. But the biopsy samples here at Boston IVF are actually sent to an outside lab to evaluate them to see, what the chromosomes look like. In that setting, we're waiting for about a 2.5 to 3 week time frame to get the results back. Typically, that is occurring by the time you've already had your period after the IVF cycle, and then we're going to proceed with a transfer in the following cycle. So it really, in total, from like start of IVF to pregnancy test when you're doing PGT, it's almost 3 months. And I know that sounds like a really long time, but there is some benefit actually to kind of waiting, having resolution of the stimulation time period, having a month off, and then preparing for a transfer where you're confidently going in with tested embryos, if that is what kind of was the decision based on your own personal scenario with your doctor. We're getting lots of questions on the Instagram Live. I'm just going to see if I can zoom through a couple of the other ones that came in early, and then I'll come back to those. So there is a question here about sperm and semen analyses, and whether or not at-home tests are also useful. I think if you're going down the road of doing an at-home test for semen analysis because something is wrong, you should just make an appointment with a fertility specialist or an OBGYN who can order a formal semen analysis. The semen analyses that you do at home typically will tell you about, is there sperm present, and maybe does it appear like there's enough, but it's not going to tell you some of the finer points that we do look for in a semen analysis, specifically what the sperm look like under the microscope, which is the morphologic appearance. Of all the things we look for, morphology is probably the thing that's most variable, and that typically we do actually find a large percentage of sperm that don't appear normal. That's actually normal. So the percent that we're looking for to be normal is about 4%. Less than 4% is considered low. But again, men, I tell my patients all the time, men produce sperm constantly. So typically if it's low once, we repeat it and just see, is this a pattern, or was that just sort of that day? So I definitely recommend, if you're thinking about semen analyses and doing an at-home kit, just make an appointment. I think it probably makes more sense for you, and you'd get better answers, and potentially be directed to someone to assist in the greater issue, which is, the overall conception process. Question about frozen embryo transfers and success stories there. So frozen embryo transfers, we do them probably at least 50% of the time, if not more. They're definitely very common here. Lots of different ways to prepare for them, whether they be normal or rather based on a natural cycle, or if we are giving estrogen to prepare the uterine lining. And there's no difference in terms of that. I should say there's no difference that we are aware of. Much of our studies on this are retrospective, but we don't have any difference that we're aware of between a natural preparation for a frozen embryo transfer and what's called a programmed cycle with estrogen or other assistant medication to prepare the uterine lining. The key really is, once we get to the point where we're starting progesterone, what does the lining look like, and how long are we doing the progesterone for, and in what manner are we giving it? And so those are some, finer points that you'll talk about with your doctor when you see them. But generally speaking, the degree of success of a transfer really depends on age at which an embryo was created and whether or not that embryo is known to be chromosomally normal or if that is unknown. So, if a patient is, transferring a tested embryo, so one that we know is expected to be chromosomally normal, then in any of those preparations I mentioned to you, the typical success rates are around 50%, 50 to, at best 60% with a single embryo transfer. If an embryo is untested, which is, also a very frequent approach, especially in younger patients, then that percentage of likelihood is different, and that really typically ranges anywhere from 20 to 40% depending on age and quality of embryo at which point it's transferred. And right now, what I just described to you, I'm talking about blastocysts. So these are day 5 embryos. Likelihood of success of day 3 embryos is a little bit more nuanced and I would say depends, a little bit harder to say just because we don't know as much about that embryo. But again, in a day 3 embryo, all of them are untested and therefore higher percentage likelihood of success when you're a little bit younger versus older, but it varies from there. Going back briefly, I did see a quick question about sperm defects and a question about head versus tails. I mean, to me, it doesn't really matter as long as there's some normal sperm in the ejaculate. If it's 4% normal or more, I really don't care about what the defect is. If it's 0% normal and they're all head defects, and it's consistently like that, I mean, in any case where it's 0% normal, I usually send you to a urologist just to have an extra look. There are occasionally things that can be associated with all head defects, something called globospermia. That's very rare, okay? I've actually never seen it. So I would just say, generally speaking, I don't make a whole lot about morphology except to say, is there some normal sperm? Yes or no? And do I need something special to find it? Or can the sperm do its job in its own natural way? And those are kinds of the things that we think about. Interesting question coming up here about a day 7 euploid blastocyst. Somebody just wrote in with a question about that. This is going back to the genetic testing and frozen embryo transfers. Recently, in the last few years, we started proceeding with expanding incubation time for embryos and allowing them an extra day. Like if they look really good on day 6, but yet they're not quite to a place where we could biopsy them, do we give them a little extra time to get to a place where we could actually biopsy and evaluate the genetic testing there? And we are doing that very commonly now. And the reason is because what we've found is that day 7 embryos do have euploid potential, and when they are euploid, they still offer an excellent potential for pregnancy. That said, when compared to day 5 or day 6 embryos, they are less likely to implant than a day 5 or day 6. So in other words, if you have a euploid embryo that's a top quality blastocyst on day 5 or 6, that has 50 to 60% likelihood of implanting and going on to a live birth. If you have a day 7 euploid blastocyst, that's closer to 30%. So there is a decreased likelihood that that embryo will implant when it's a day 7 embryo. But if it does, we are hopeful that it will have that live birth potential just like the day 5 and 6 ones. Going on, some questions about PCOS that I did want to talk about a little bit. So PCOS is a very common issue that arises and that we often find in the fertility world. Certainly those of you with PCOS know that it affects more than just fertility. This is a general really a metabolic disorder where it can affect, not just fertility, but other issues in general in terms of weight gain, mental health challenges with depression. It can be a little bit more common in women with PCOS. Things like acne, hair growth, hirsutism. So all of you who have PCOS out there probably have some familiarity with what I'm mentioning. But I think in general, when we talk about lifestyle changes for PCOS women, I think we're primarily talking about being mindful of food choices. So, trying to stay more with nice, balanced diet, whole grains, staying away from processed foods, increasing proteins and leafy green vegetables. Frankly, all the things that probably all of us should be doing, but more important and certainly more sensitive for women with PCOS. There are a lot of PCOS-related diet recommendations out there. I would just be cautious about what you're looking at and reading, and try to go to sources that can be trusted. A quick shout out to one of our nutritionists here, Hillary Wright, who has really specialized in PCOS, and she actually has a book out there on PCOS, so that would be one source, certainly not the only one. There's so many sources, so you can check that out. But I think in terms of importance of exercise is super important in all patients, but again, women with PCOS primarily. One of the things that I pay close attention to when my patients come in for with an evaluation for PCOS, we talk a lot about androgens. We talk a lot about insulin resistance, because that is really underlying primarily the cause of PCOS. Even when we can't see it as like a laboratory result that comes through, with like an elevated hemoglobin A1C, still we know that the primary issue with rising testosterone levels is an underlying issue with insulin resistance. So one of our primary ways to manage this is to think about ways to improve insulin sensitivity, and we can do that with some supplements and or medication. One of the supplements that I really like is myo-inositol. This helps to improve insulin sensitivity, and it does it in such a way that there are really few, if any, side effects. This supplement came out of the diabetic literature actually like back in, I want to say like 2010, and it has since been used and found very helpful in women with PCOS. One of the preparations that I really, really like is one called Ovasitol. It's Ovasitol. It's from a company called Theralogics. I have no relation to this company or anything like that, but I just mention it because I think they do a really nice job at packaging the supplement, giving some instructions for it. It's a nice bioavailability. My patients really like it, and it's done really, really great things for decreasing testosterone levels. So in some of my patients that have really elevated levels, if I start them on Ovasitol and then I check it, months later, that testosterone level is often cut in half. So I love Ovasitol. I think it's great. Some patients need more than this. So in patients that have very clear, insulin resistance that is showing up in the form of an elevated hemoglobin A1C, I recommend starting metformin. Quick flip back. Someone was just asking about the other supplement I mentioned is called Ovasitol. It's Ovasitol. Ovasitol. Okay. Metformin is a prescription medication. that your doctor would need to prescribe you. I use it very frequently in my treatment of women with PCOS, especially if we have that elevated hemoglobin A1C, or in settings of what's like a very traditional appearance of PCOS, which is more like central weight gain and a little bit more of the hirsutism, as opposed to another kind of PCOS that we sometimes talk about called lean PCOS, without that central weight gain but elevated testosterone levels. So it's nuanced, but these are some of the options that we use. But again, I think for anyone with PCOS, our primary goal is, try to be mindful about what you're eating, stay away from processed foods, high sugar, processed carbs, try to steer more towards whole grains, leafy greens, exercise daily. These are the things that are going to help you, in trying to maybe make ovulation more regular, or even if you're in treatment, all these interventions can really improve responsiveness to treatment and improve uterine lining. Someone here is asking about does PCOS affect the quality of eggs? So there is some data out there to suggest that women with PCOS may have a slightly higher rate of abnormal eggs. So for those of you with PCOS, you may remember conversations about having big ovarian reserves and lots of eggs in the ovaries. And sometimes, having all of that doesn't necessarily mean that you're going to have like huge amounts of normal embryos, and some of you may have experienced this. You get an egg retrieval of lots and lots of embryos, or lots of eggs, but then maybe you only end up with a few good quality embryos in the end. This may have something to do with PCOS. We think that probably there is some interaction there, but I think the data is still a little mixed. Some of that data on abnormal chromosomes came from a study out of China looking at miscarriage rates in women with PCOS. So, anyways, I think women with PCOS tend to have the benefit of lots and lots of eggs to work with, but may there be some issue with that egg quality? Potentially, but it's almost always something that we can overcome. So I think some other questions that had come up. A couple questions about sperm again, related to supplements to improve sperm. I don't really have any good recommendations for you. I usually mention to my patients, again, healthy diet, healthy exercise lifestyle. A couple things that we do know that can negatively impact sperm. Hot tub use, a lot of just really heat around the groin area, whether that be like you're, a horseback rider or you're a biker or things like that. Those can have, if you're doing that for hours and hours a day, that can certainly impact sperm. Also interesting is that frequency of ejaculation also impacts quality of sperm. So the best quality sperm is usually achieved with frequent ejaculation, like every 2 to 3 days kind of situation. So that's something to keep in mind when producing a sample for either IVF, IUI, or if you're doing an initial semen analysis, you want to definitely have that as a reminder that abstinence is not actually helpful in this situation. But otherwise, I think, just like a regular vitamin is fine for that. I'm just going to scroll a little bit here and see about some of the questions that I've missed. There are some questions about scratch biopsies before doing an embryo transfer. That is something that is offered I would say it's more selective. It's not really a widely used technique because, again, as with so many things in this field, there's some mixed information on it, whether or not it's really helpful. There was some suggestion, blanking on the study right now, but it was probably like 5 years ago or so that looked at performing a scratch biopsy, which is really just an endometrial biopsy, okay? So that can be done for a number of reasons, but if there is a biopsy done, this question of whether or not that will improve the likelihood of implantation following that biopsy. And I think if I'm recalling the study correctly, it was, the best data showed that in the month or 2 months after the scratch was the highest implantation rate. But it wasn't really the strongest of studies. So I would just say, that would be a tool that we might reach to if we were in a situation where we were having like lots of failed implantation. And even then, the question of whether or not that's really useful, I think you'd have to talk about with your doctor based on your case. Hold on. Sorry about that. Okay, other questions. We talked about sperm. What kind of progress for the male in IVF? I'm not so sure about what that question meant. In terms of sperm, what are the things that we can do if sperm is a factor? Lots of things. So the first thing to say is there's lots of different sperm issues that we can run into. Male factor is about 50% of the equation, and not surprisingly in the world of IVF and infertility rather. So if we find that there's issues with sperm, sometimes if they're just really mild, like the count's a little bit low, morphology is a little bit low, motility is a little bit low, an IUI might be enough. What we do with that is we're concentrating sperm into a small catheter with a little bit of fluid. We're placing that into the uterus high up in the uterine tract. So we're bypassing obstacles like the vagina, the cervix. We're getting that sperm all the way up into the uterus so sperm and egg can meet in the fallopian tubes. And that IUI might be enough. In cases of more significant sperm factors, like really low numbers, low motility, like I said, 0% morphology, things of that nature, then we typically go to IVF. And that is so that we can be able to do something called ICSI, intracytoplasmic sperm injection, which is a process in which an embryologist individually selects a sperm that looks really good, that's normal shape, that's moving, and injects that sperm into an individual egg. This is really a mechanical way to fertilize an egg. It assures that egg and sperm meet, because the other way that we do use fertilization in IVF is just with what we call regular insemination, which is concentrating sperm in droplets and placing it over the eggs, and allowing sperm and egg to swim and meet each other. So I would say, we have ICSI as like our primary tool for overcoming really the vast majority of issues that we see in a semen analysis. Now, some places where this wouldn't be possible would be if there is no sperm found in the ejaculate, which is something that we see not so infrequently. And when that happens, that then requires our colleagues in urology to assist us. So here at Boston IVF, we have, a number of great primary reproductive urologists to help us in those situations, and really many of the male factor situations. Just a quick note to say that not all urologists are reproductive urologists. So it's very common where I'll see a patient and they'll say, well, I already saw a urologist, but when we really start digging, it's sort of a generalist, which sometimes they can be great, but most of the time we really want someone who specializes in reproductive urology, because it's just a lot more specific, and there are very specific tests that we typically have to do in these scenarios. So anyways, in a scenario in which there was no sperm, we would certainly send you to one of our great reproductive urology colleagues to assist with a potential sperm extraction. And this is a surgical procedure, or potentially to assist in, if they think there's an obstruction or something else going on there. There's lots and lots of different things that we would be working for here. So that's just a little bit more about sperm. Let me just again, pardon me scrolling through. Someone was asking about acupuncture. I think acupuncture, if you find it relaxing, is great. I think I've literally had one patient try acupuncture after we had a discussion about the possibility that maybe it could be something that she wanted to try, around the time of transfer or during her IVF cycle. And she came back and said, I hate needles and I hated acupuncture. So I was like, don't do it. So it's not something that's a silver bullet here, but, I think acupuncture can be a really nice adjunct to your treatment. Our most popular time that patients tend to use it is before and after transfer. Again, I don't think that this is going to be the thing that makes a difference, but might it be helpful for you for a variety of reasons? Yeah, I think it might be. I think the typical benefits I talk to my patients are about, number one, that acupuncture really does help to sort of change blood flow a bit and sort of concentrate it in a certain area. So we talk about the fact that with fertility specific acupuncture, we may be bringing a little bit of extra blood volume to the reproductive organs. So that could be beneficial, especially around the time of implantation. Other things that we talk about with acupuncture, or that I talk with my patients about with acupuncture, is, I think it's a way for us to give ourselves some self-care. I think it's a nice opportunity for patients to kind of be in the moment, give themselves a little bit of a mental support and break. So I find it useful for all the things. Like if it feels good, if it's supportive to you, if you like it, I think this is great. It can have some benefit for sure with blood flow. And even some of my patients who have irregular periods have found that it's helpful in regulating them a little bit more. Again, I don't think it's the thing that's going to dramatically change your treatment outcome, but I think it's something to consider, and it often feels really good for some of our patients. Another question I had that came up was, this is a great general question. Basic testing, infertility testing, AMH, FSH, ovarian reserve. What the heck does that mean? So this is really what we would be talking about a lot if you came in for an initial visit. So ovarian reserve is a vague term that refers to the idea of quantity of eggs in the ovaries and how much there is remaining in the ovary when you get the test done. Now, this isn't an actual number. It's not like you have, 7,000 eggs remaining, or it's nothing like that. It's a statement or an evaluation that's multifactorial, that looks at sort of, is your ovarian reserve where it would be expected to be given your age? Is it better than average? Is it average? Is it less than average? Is it diminished? Is it low? What I always tell my patients, especially my egg freeze patients that are coming in wondering about doing egg freezing, is that ovarian reserve and spontaneous conception or ability to conceive are two very different things. Now, for many of you coming in for fertility-related reasons, when you have infertility already established and you have low ovarian reserve, which I'll talk about more specifically again in just a minute, then we think that ovarian reserve being low is a factor in the problem. But in general, when you haven't tried to conceive, does low ovarian reserve mean that you will have trouble conceiving? No, they're not related like that. And we know this from a pretty big study that was done in the Netherlands, probably now like almost 7 or 8 years ago, looking at AMH levels. So AMH, we'll get back to that in just a minute, but looking at AMH levels and looking at spontaneous conception. And what we found with that study was that AMH can be high, it can be average, it can be low, and still women can conceive completely in the normal time frame for spontaneous conception in that 6 to 12 month time window. So low ovarian reserve does not equal infertility, okay? AMH is really a hormone that's released by the eggs themselves, and that is the hormone that gives us the best understanding of the quantity of eggs in the ovaries. Again, broadly speaking, a lot, a moderate amount, a little bit. FSH is a hormone secreted by the brain, by the pituitary gland, that tells the ovary, in large part, to grow and develop a follicle. So for women, we have follicles every month that we're menstruating. There are follicles that are available in the ovary that can be stimulated. And typically, of those many follicles, usually one will grow and develop to become a large follicle that releases an egg mid-cycle at the time of ovulation. FSH is the hormone that's responsible for stimulating the growth of that follicle. FSH is really important when we're thinking about fertility and fertility treatment, because FSH, if it's already high, if the ovary is already saturated with FSH, it means that I can't give you more to get the ovary to do more. It basically is saying that the body is already at maximum capacity, working as hard as it can to do as much as it can with the ovaries, and I can't do a whole lot more from that standpoint of stimulation, okay? If FSH is normal, then typically I have, wiggle room for stimulating the ovaries in addition to what they're already being stimulated at, and that is important when it comes to IVF. So that's why we care so much about FSH, AMH, and often part of this evaluation is also an AFC, which means antral follicle count. That's the ovarian ultrasound assessment of the follicles. So these are the things that we really talk a lot about in our first visit of a fertility evaluation, and really so much of it's about education. So I think we've hit most of the topics here. We've been talking for a little bit. So, I just wanted to give you a couple of things to think about as closing. I love that everybody out there and on this Instagram is really trying to get more information for themselves and to educate themselves. I think that's phenomenal, and that's being a proactive patient and, advocating for yourself. I think no matter where you are in your process, I would definitely encourage you to reach out sooner than later if you haven't already connected with a doctor, just to, have somebody help you, walk you through this process. For those of you that are in treatment, I know that this can feel long, and I would just say, as your doctors, we will all be working so hard and trying our very best to get you the best outcome in the soonest time frame. Sometimes that's quickly, and sometimes it's not. And the key to success, the key to success is staying in treatment. And the key to staying in treatment is finding ways to manage and cope with the stress of treatment and infertility and subfertility. And my best recommendation to you, if that's something that you're struggling with, is to, find a way to build your support system, whether that's your partner or friends or family or a therapist or our wellness center, or a, Facebook group or something, some way to help you feel supported, some way to help you feel like you're not alone, because I'm telling you, you are not alone. I am seeing patients all day long, every day, with patients lining up out the door. You are not alone. This is common, more common than you think. And the good news is that our treatments are really, really successful most of the time. And even if the traditional way is not successful, there are other ways that we can talk about that will be successful. So, the point to leave you with is that family building and building the family of your dreams is and always will be a possibility. And we will get there one way or another. You just have to hang in there with us, whether it be me or with your doctor, another doctor at Boston IVF, you'll get there. So anyways, thanks for hanging out with me today. And I'll look forward to maybe seeing some of you in the office.